This presentation is on Chapter 14, Personal Health Records. The definition in the book has two definitions. One comes from the Personal Health Records Task Force of the Medical Library Association and the National Library of Medicine. They state that electronic health records is a private, secure application through which an individual may access, manage, and share his or her health information. The personal health records can include information that is entered by the consumer and or data from other sources such as the pharmacy, laboratories, and healthcare providers. The personal health records may or may not include information from the electronic health records that is maintained by the healthcare provider and it's not the same thing as the electronic health records. Another definition comes from the Connecting for Health Personal Health Working Group of the Marco Foundation. They define personal health records as an electronic tool that enables individuals or their authorized representatives to control personal health information and supports them in managing their health and well-being and enhances their interactions with the healthcare professionals. A little bit of a story or the development of the electronic personal health records. Many individuals have long kept their paper records on their healthcare as adjuncts to their medical records. Some of the examples include paper records of immunization and a list of prescriptions of medications and medical problems that people may keep with their personal files. Paper records serves several important functions. For example, they minimize the need for individuals to remember their details of their medical history. They are portable and they can be shared too. There is some evidence that paper records may facilitate health behaviors. The development and adoption of the personal health records in the United States is the result of several historical trends. For example, the rise of the computer devices and the internet. Also, the development of electronic health records and governmental policies related to health information technology. And also consumer demands for the function provided by personal health records. In 2004, it was estimated that 64% of the U.S. adults own a smartphone. This percentage is continuing to increase, and while the widespread adoption and use of personal computer devices in the internet provide the infrastructure that makes personal health records possible, electronic health records serves as the primary source of the electronic health records. In recent years, the U.S. government implemented policies specially intended to increase the adoption of both the electronic health records and personal health records. The HIPAA, the Health Information Portability and Accountability Act of 1996, requires individuals to be granted access to the healthcare records upon request. In addition, the law requires individuals to be provided with an audit trail describing who has access to their health information and why. HIPAA does not require this information to be provided or are most easily addressed with electronic records. HIPAA could be seen as the first step in encouraging the adoption of personal health records. In 2009, the American Reimbursement and Recovery Act of 2009 authorized the Center for Medicaid and Medicare Services to provide financial incentives for adoption and meaningful use of electronic health records. In September 2012, the Office of National Coordinator finalized requirements that eligible providers who has met stage 1 requires would need to meet stage 2 requirements in 2014 in order to be compliant. The final and possibly the most important trend leading to the adoption of personal health records is individual desire for the functions that personal health records provide. In 2005, a survey by the Marco Foundation found that 60% of those interviewed wanted a personal health records that they could use for refilling prescriptions, communicating with the doctor, and obtaining results over the internet. In addition, over 70% supported the use of such system that allows providers to review their medical records when needed. With technology, now there's an application called Blue Button. This application is for patient access to electronic health records. The idea of patient access to electronic health records has been discussed and debated since 1990. The idea of the Blue Button application was developed during a meeting of the Marco Connecting for Health Work Group in 2010. The vision was that by clicking on an image of a button, patients could access the records in either human-readable or machine-readable format. The symbol for Blue Button and the slogan, "Download my data," are used to identify electronic access to health data views, downloads, and transmissions. The Blue Button application includes clinical, demographic, financial, and other information related to the health and medical care of patients. One of the first institutions that started this Blue Button was the VA, Social Security Administration, and later was adopted by private health insurance, hospitals, and healthcare practices. The Blue Button challenges were designed to stimulate development of products by the public and private organizations to make health information more usable and meaningful for the consumer. The organization or national coordinator provides an online tool, the Blue Button Connector, to help patients find their health data so they can reference, check, share, and use the application. The Blue Button Connector users can select a source of their health information. For example, their health insurance, the hospital, the clinic, the providers, the pharmacy, and immunizations. As they can see the features that are available, and they can download and securely send records through the application. The Blue Button Connector provides a list of health applications accepting information provided using national recognized standards. The question remains whether providing patient access to their health information makes any difference. They calculated the number of positive outcomes reported for every outcome measure investigated, finding mixed outcomes across both patient and providers, with approximately half of the reviews being positive changes. The principles of our ideal personal health records. There's a table on page 245 where table 14.1, where it says the core principles of personal health records designed for connecting for help. The first one, there's 9 of them. The first one is openness and transparency. And this means that consumers should know what information has been collected about them, the purpose of its use, who can access and use it, and where it's located. They should also be informed about how they may obtain access to information collected about them and how they may control who has access to it. The second one, number 2, is purpose specification. The purpose for which personal data are collected should be specified at the time of collection. And eventually, the use should be limited to those purposes and others that are specified on each occasion of change of purpose. Number 3 is collection, limitation, and data minimization. Personal health information should only be collected for specific purposes, and it should be obtained by lawful and fair means. The collection and storage of personal health data should be limited to that information necessary to carry out these specific purposes. Where possible, consumers should have the knowledge of and provide consent for the collection of their personal health information. Number 4 is use limitation. Personal data should not be disclosed, made available, or otherwise used for purposes other than those specified. Number 5 is individual participation and control. Consumers should be able to control access to their personal information. They should know who is storing what information on them and how that information is being used. They should also be able to review the way their information is being used and stored. Number 6 is data quality and integrity. All personal data collected should be relevant to the purposes for which they are being used and should be accurate, complete, and up to date. Number 7 is security safeguards and controls. Reasonable safeguards should protect personal data against such risks as loss or unauthorized access, use, destruction, modification, and disclosure. Number 8 is accountability and oversight. Entities in control of personal health information must be held accountable for implementing these principles. Number 9 is remedies. Remedies must exist to address security breaches and privacy violations. For the personal, the idea of personal health records should be comprehensive. The data ownership and control and privacy. This means that the users should control access to the personal health records and be able to annotate data created by others. The system should be available for the users regardless of physical location. The system should allow users to share all or parts of the personal health records to others. The system should provide a convenient means for users to access their health-related information and services. For example, should include the capability for secure messaging between patients and healthcare providers. The system should provide users with unique services that are otherwise unavailable. Also, the system might provide a translation service to help individuals understand clinical notes from the electronic health records. Such information could be tailored to users' health literacy and numeracy. However, the ability to consumers to customize content in personal health records has yet to be implemented. There are different types of personal health records. The first one I'm going to talk about is called standalone personal health records. These systems might be of use in particular cases. For example, the capability for emergency medical providers to access the person's USB stored in the data. This system has never adopted for many institutions, and it's more likely because they require manual data entry by the user, and the records are not interoperable with other systems, such as the electronic health records. Another type is the untethered personal health records. These are web-based systems separate from the electronic health records. The advantages of these systems over standalone personal health records is that they're accessible anytime and can aggregate data from multiple sources. Another type is the tethered personal health records. Now, these are linked to a single clinic or healthcare provider. Because these systems allow the users to view electronic health records data via the personal health records, they are sometimes called patient portal. There are several advantages of these systems. They are often provide direct access to functions so they can message their healthcare provider. They can request medication refills, and they can schedule appointments. And because the personal health records is usually automatically populated with electronic health records data, they require much less manual entry. The main disadvantage is that the information is linked only to one specific healthcare provider or system. This creates a problem for individuals with multiple healthcare providers in different healthcare systems, because only the information from the linked system is represented in the electronic health records. Another type of personal health records is the network personal health records. In these systems, patients can integrate data from multiple sources, from different healthcare providers, health plans, and laboratories. The data are integrated through the use of access services that conduct users' authentication before allowing patients or their representatives to access their data. Ideally, users sign in once and gain access to comprehensive integrated data. As with electronic health records, the development of comprehensive integrated personal health records depends on the wide implementation of data representation and the data exchange standards that are still needed to create interoperable records.